Welcome to everybody. This is the webinar, Lupus and COVID-19 Emerging Research Findings. I'm Margaret Smith. I'm the manager of the Lupus and APS Center at Hospital for Special Surgery in New York City, and I'm joined by my fellow panelists in welcoming you today. So on our panel, we have three of my colleagues, Dr. Sebastian Satui, Dr. Medha Barbaya, and Jillian Rose, PhD. Dr. Satui hails originally from Lima, Peru, and he is a fellow in the Department of Rheumatology at Hospital for Special Surgery. As well, he's affiliated with the COVID-19 Global Research Alliance, and he is the New York, New Jersey lead for that organization, as well as being on the clinical advisory and scientific panel. Dr. Barbaya is an assistant attending physician at the Hospital for Special Surgery in the Department of Rheumatology, and she is also an assistant professor of medicine at Weill Cornell Medical College. Her clinical and research care centers on patients with lupus and antiphospholipid syndrome, and she's done quite a bit of research into the environmental risk factors for lupus and other rheumatic diseases. And then our third panelist is Jillian Rose, PhD, and she is the Director for Community Engagement, Research, and Diversity. And her research focuses on psychosocial impacts of lupus and other rheumatic diseases on people who live with those conditions, and also on developing interventions that best meet the needs of those individuals. So today's program is a follow-up to a webinar that we held in mid-April, and many of you were with us for that webinar as well. And at that time, part of your feedback told us that you were interested in hearing more about research into COVID-19 and lupus as that research became available. As you might recall, at that point in time, there was so much that we didn't know. There were things that we felt theoretical could be true, but a lot needed to be done. And so we today have found that there has been research that has been done in the course of that time, and of course you keep up with this on your own, obviously through the press. But we have today information to present to you that will give you more of a sense of what people are discovering and what is true. So what you're going to hear from today is information about a global registry of rheumatology patients and their experiences with COVID-19. And as well, you're going to be hearing about some of the new drug trials and what we have and have not discovered from those. Then we're going to talk about a long-term registry of rheumatology patients at HSS and what such registries are helping us discern about the risks and the medical management of people with those conditions. And then finally, we're going to close with a discussion about the psychosocial impacts of COVID-19 on people with lupus and other rheumatic diseases, whether or not they have experienced COVID-19. So we will leave time for questions and answers, and I encourage you to input your questions into the dialogue box as they come to you, and we will get to them. Okay, so I would like to open it up with our first speaker, and Dr. Satui, would you please take the stage and activate your slides, please?
So
okay.
As Margaret already told everyone, the topics for today are lupus and COVID-19 and what are the emerging research findings. So hopefully that's what we're trying to answer some of the questions that you might have. Next slide, please. These are a little bit of the disclosures, which basically just kind of talks about me and my position in the Global Rheumatology Alliance. Next slide. And this is what I will be talking about. So COVID-19 and rheumatic diseases. I'm going to be briefly mentioning what the COVID-19 Global Rheumatology Alliance is, talking a little bit about the mission of the Alliance, as well as some of the registries and projects that are going on. I'm going to talk about the latest analysis that has already been published there, and this is probably the largest experience so far with patients with rheumatic diseases. And then briefly also talking about what we know from this data on lupus and patients on Plaquenil or hydroxychloroquine. And then I will be also covering a little bit of the information that is out there about the use of anti-rheumatic medications for COVID-19. Certainly talking about Plaquenil, talking about glucocorticoids, as we know them, steroids, prednisone being the most common example, and some of these other medications. Next slide. So the data from the COVID-19 global GRA, which I'm going to say that for simplicity. So how did this alliance got established? So basically, the alliance got established as a response from the global rheumatology community to the pandemic. So a lot of physicians and rheumatologists worldwide, the same as kind of what Margaret was talking about, how where we were some months ago, identified a gap in the information, and this information was needed in order to better inform ourselves and guide our patients through the pandemic. So after some discussions on March 11, on Twitter, there was literally a call out on who would be interested in participating in this effort. And from the few of us who were involved in this has actually evolved to the alliance that has over 400 members that include also patient representative. This is worldwide, so patients and rheumatologists in multiple countries. And to date, it's actually supported by over 100 organizations, actually 240, I think is the latest count, which include patient organizations, hospitals, health systems, and most importantly, the American College of Rheumatology, the ACR, which is, and the European League Against Rheumatism, which is a European counterpart for the American College of Rheumatology. So what are the activities and what are a little bit about the numbers up to date? So there's a provider registry, which basically is focused on rheumatologists reporting their patients who have had COVID, what have their characteristics been, what are the outcomes. And as of June 16th, which is when I did the slides, there were a little bit over 3,000 patients already reported worldwide, probably 2/3 of them coming from Europe, but the numbers keep growing on a daily basis. There is also a patient survey or a patient experience survey that allows patients to actually go in and report on different aspects of how the pandemic has impacted their life. This is for patients who had COVID or haven't had COVID, in order to kind of identify and capture some more information that are important for our patients as well. So up to June 16, there were almost 12,500 entries. Of those, 702 patients had actually been diagnosed with COVID. At the same time, there's several groups that have been working what we call systematic literature reviews, which is basically pulling all the information that is out there, all the publications, all the scientific reports, trying to cover and answer some important questions. Two of them being, for example, the use of anti-rheumatic drugs for treatment of COVID. And then by what we knew already, or kind of trying to get a little more information of the viral complications, so viral infections in patients who are on anti-rheumatic medications. There's also been a pretty important piece of advocacy as well, trying to kind of advise for the responsible use of hydroxychloroquine in COVID-19, trying to amplify the voice of our patients, knowing that there has been drug shortages that impact the patients with lupus and RA who depend on this medication. And at the same time now, we are part of the American College of Rheumatology, and there's several proposals trying to better understand and better guide both rheumatologists and patients during the pandemic and what will come after. Next slide. So briefly, before I kind of keep talking about what this registry data, but what is a registry? So a registry is basically a collection of patient data. It enables the study of many people over a long period of time, or people kind of worldwide as well, which is kind of one of the strength of the COVID-19 GRA registry. The data can include information on the person, such as age and sex, and also eventually, in some cases, some biological specimens as blood to answer some other more questions. In this case, most of the data we have is just demographics and disease specifics and medications and outcomes. It is useful in examining effects of a disease in a group of people and generating further research hypotheses. And it is established with patient consent, an overview of a review board in order to secure adequate use of the data and protection of patient information. Next slide. And just briefly, kind of this is a map showing where most of the cases, this is up to June 10th, have been reported in the registry. As you can see from the color legend over there, most of them have come from Europe, and their friends in Spain and the UK as well. But then next, please. You can see this is kind of the Northeast, and New York has certainly been also one of, on the US side, one of the main contributors. So This is actually still, like I said, growing on a daily basis. Next. So what I'm going to briefly talk about right now is the data that was analyzed, and this included the first 600 patients that were added to the registry, and the 600 patients actually came from 40 different countries. This publication was actually published in Annals of Rheumatic Diseases, which is one of the larger journals in rheumatology. Next. And who were the patients actually in the 600 patients? So most of the patients, so 38% of those 600 patients had RA, then followed by lupus, who was the second most common disease represented in this group. And some of the other conditions were psoriatic arthritis with 12%, axial spondylitis, patients with vasculitis, 7%, and then just this group of other that are these other conditions. What we also knew from these patients is that 80% of them actually had minimal no disease activity by the time that this data was captured and at the time they had COVID infection. And only 20% of them had high disease activity. Next. And as we would expect when we were talking about rheumatic conditions, the larger percentage were women. So around 70% of the 600 patients were women. Actually, around also 70% were 50 years or older. Then around almost 45% or so of these patients were actually hospitalized. The rest of them, so 55% approximately, were actually managed with their infection at home. They didn't require hospitalization. And only a small percentage of the patients, of the 600 patients, died, less than 10% of them. The rest actually survived. So broadly talking about how was COVID and what the characteristics were, and what this paper was focused on is actually trying to see what determined or what factors were associated to hospitalization. So hospitalization, being hospitalized or having disease severity enough to require hospitalization was the main kind of factor studied here. The duration of symptoms in all these patients was 2 weeks, which is actually quite similar to the general population. The general risk factors of hospitalization were age over 65, history of high blood pressure, history of lung disease, history of diabetes, and a history of a chronic kidney disease. And all this, next, are quite similar to what we knew on just general population, meaning patients who don't have necessarily a rheumatic disease. Next. And then if there wasn't any association between what was the underlying rheumatic diagnosis and if this was associated to being hospitalized or not, there was actually, next, no specific rheumatic disease that was associated with hospitalization or worse outcomes. As you can see, next, there is a little bit of an increase in the numbers in patients with lupus. So only 11% of them were of the patients that were not hospitalized were patients with lupus. Well, from the hospitalized patients, 17%. So that number does grow a little bit, and the same for the patients with vasculitis. This overrepresentation for lupus and vasculitis is probably more related to the fact that what we know is that patients with lupus and vasculitis have probably a higher, or more commonly experience other conditions like hypertension, kidney disease, lung disease, which would probably therefore put them at high risk for requiring or having a more severe presentation rather than specifically the disease itself. Next. And then we looked about into what were they looked about the medications and what were, if this were associated or not with risk of worse outcomes. So with regards to glucocorticoids, meaning steroids, prednisolone, Medrol, next. What this study showed was that a moderate dose at baseline, so this was people who were taking 10 milligrams or more of prednisone prior to their infection, they actually presented an increased risk for hospitalization. Other medications like NSAIDs, meloxicam, ibuprofen, or other oral antirheumatic agents such as Plaquenil, methotrexate, azathioprine, next, were not associated with an increased risk of hospitalization. Leflunomide or Arava is actually included within this group as well. And then with regards to biologic agents, next, what was actually described was patients who were on a TNF inhibitor, so adalimumab or Humira or etanercept or Enbrel, actually were at a decreased risk of hospitalization. When looking into other agents next, such as the number like rituximab or Benlysta, the numbers were too small to analyze. So certainly there will be more information coming because, as I said, this study only included 600 patients, and the registry has now exceeded 3,000. And there will be kind of an interest into looking further into what is the association with outcomes in patients with COVID-19 who were on these medications before the infection. Next. And then specifically with the topic of lupus, there was, prior to this analysis, there was a short analysis as well, but some other investigators in the Alliance who looked into 80 patients with a history of lupus and COVID-19 infection. And from these 80 patients, 51 of them actually were on Plaquenil or hydroxychloroquine prior to the infection, while 29 of them were not. And what they reported was that there was no difference in hospitalization between those on Plaquenil and those who were not on it, and that there was no difference in the maximum level of care, meaning that they requiring oxygen, having to be in an ICU, requiring mechanical ventilation. There was no difference between those who were on Plaquenil and those who were not on it. Next. And because of this growing information on that kind of calming down the initial excitement of Plaquenil, there have been several activities trying to actually advise on the rational assessment of the information, the dissemination of information, and probably inadequate dissemination of information and decision making based on this has also been one of the issues that we all have had to deal with during the pandemic. And the multiple investigators, including myself from the Alliance, have been trying to actually redirect the use of this. And the American College of Rheumatology has also been very vocal, trying to secure an adequate supply for our patients. Next. But the data that from the Alliance certainly has some limitations, and there are some next steps to look forward into as well. So the risk of COVID-19 and infection in patients with lupus and other rheumatic diseases cannot be fully assessed because for at least from the provider registry, we're only looking into patients who had already the infection. So there are other ongoing studies such as the GRA patient registry, the HSS cohort, that might better be able to do so. And however, a few small studies, mostly coming from Europe, have reported that there's either a similar or maybe a mildly increased risk. And then it's vital to continue collecting the data. So this will generate important information and allow us to, bigger numbers will allow us to actually focus on specific rheumatic diseases as well, to better answer the questions from all the patients and from providers who want to know how to deal with this. And there's going to be this continued collaboration with the ACR to hopefully provide more information for everyone. Next. And now with regards to the use of anti-rheumatic medications for COVID-19. Next. So one important thing, a couple of concepts that I wanted to kind of discuss briefly before going into what is out there and what has been reported is that there are limitations to several of the studies out there yet, and hopefully now better studies are coming out that will better address the question. But from all the information that has been out there, it has created a lot of the initial hype on these medications. A big issue is there's what we call a lack of a control arm, meaning to really understand what the medication is doing for someone, you need to actually know what's happening to someone with similar characteristics that is not getting the medication. Reporting just on a group of people who are getting the medication doesn't allow that comparison. There's always there are going to be issues with what we usually call confounders, which are characteristics of factors or factors that might influence the outcomes and that they're not being studied or taken into account. And there's been a big issue with the rigor and transparency in research reported. There's been understandably a haste and like a need for actually information to be out there to guide our decisions, to guide our patient care. But the haste to disseminate results has, in some cases, led to probably unjustified excitement or some decisions being taken without the actual data to back them up. Next. So with regard to Plaquenil and hydroxychloroquine, which was one of the first agents to be brought up, there's been the studies, especially the ones earlier on, had several limitations, and I'm not going to get in specifically into any of them, but what I can tell from the larger, what we call randomized studies, two studies that looked into looked into death as the outcome, meaning if Plaquenil would protect you or from death, actually showed that patients who were on Plaquenil compared to those who were not didn't have any benefit, no harm. 3 studies that looked into if Plaquenil had any association with needing a mechanical ventilation or being intubated or death, neither of them showed, like when pulling that data, neither of them also showed no benefit, no harm. And there was one recent study done in the US that actually used Plaquenil in over 800 patients to try to prevent the development of the infection. So patients who were exposed received Plaquenil at least maximum of 4 days after their exposure. And what it did show, it was that there was also neither benefit, meaning that the patients there was no difference between the patients who took Plaquenil or not with regards to them developing the infection, but there was also no harm. And this is important because there's also been some data out there that has kind of emphasized or probably overexpressed the potential harms of Plaquenil, which is certainly something that could be concerning for patients who have been on it for a while. Some of the studies, like I said, have several flaws. Even the larger one has been retracted from the literature for some issues with the data. But the important thing is that we know that in patients with lupus and patients with RA, Plaquenil is usually a well-tolerated medication. And that importantly, whatever is derived from the COVID data, COVID patients are completely different to the patients that we see in our clinic and our patients. So the data is not like those risks, whatever they are, if they are difficult to extrapolate to patients with lupus. Next slide. With regards to steroids, there's been several studies also talking about this, comparing patients on and off, and there are so many differences between them. When was the medication given, what dose of medication, which steroid was given, and then the patient groups as well. Like COVID is a very heterogeneous disease in the sense of the clinical presentations, the complications that we see with them. So kind of pulling all this data, like the studies all go into different directions with regards to if there's a benefit or not. There are very mixed results. But next, probably a lot of people next, and this is, I think, one of the most conservative headlines heard, and about the recovery study that showed that dexamethasone proved the first life-saving drug. Next. Actually, so what do we know from the press release? And actually the full data just became available, I believe, yesterday morning, and I've already gone through that analysis, but this is kind of the main take-home points from that as well, is that dexamethasone, which is a medication like prednisone, was used in patients with COVID who were hospitalized, and basically these patients got up to 10 days of treatment with the medication. So what this study reported was, for patients who were on mechanical ventilation, meaning they were intubated, the use of dexamethasone, so if you treated 8 patients with dexamethasone, you prevented 1 death. So there was a significant reduction of 1/3 in the risk of dying by using dexamethasone. For patients who were on supplemental oxygen, meaning you were in the hospital, you were requiring some degree of oxygen, not as bad as mechanical ventilation, if you treated 25 patients with dexamethasone, you actually prevented 1 death as well. So there was a 20% decrease in the risk while using dexamethasone. But for patients who were not requiring any oxygen, so people who had COVID but were not sick enough to require oxygen, so there was no benefit observed. Okay, so next slide. So like I said, the results are out now. This is a brief summary of that, and I think those are the main take-home points. So the one question that might come up of this is like, okay, so initially there were some studies that actually showed that if you were on a higher doses of prednisone at the beginning, your COVID could be worse, but now you tell me that COVID actually can get better with steroids. So next slide. And this goes to the important point of what is the timing of the medical intervention, in this case of use of steroids. So what is driving the illness? If it's the virus at the beginning, and then if the immune system kind of becomes hyper-stimulated, and that is the main complication. It's also important because the immune systems or defenses have different arms, and they act at different times as well. So when you kind of blunt them or decrease their activity with steroids, it's also very important. Like I said, COVID is a very kind of heterogeneous disease, so it's also important who gets them as well, because clearly the patient who's requiring mechanical ventilation is not the same as a patient who was able to kind of go through COVID without requiring oxygen. And there are always risks with the use of missed medications, which include weakening the immune system more and kind of leading to other infections being involved. Next. And then there are several other medications that are being used. I'm mentioning some of them: tocilizumab, which is a medication used in RA, and anakinra, and other medications as well, which I'm not necessarily going to go through them. But the main take-home point is that the studies that are out there still are small studies that are more hypothesis generating and kind of and are not definitive. So it's important to know that although there is potentially an arm, that the data and the jury on this is still out there, and we need to better understand not only if they really help or not, but who needs to receive those medications in order to benefit from them. Next. So with that being said, I just wanted to thank. This is the global the GRA's web page. If you want to go, there's data there. There are patient resources as well, and thank you for the opportunity to present some of this data.
Great. Thank you, Dr. Satoui. Appreciate that. So, Dr. Barbaya, would you please take the stage?
Absolutely. Thank you so much, Margaret, for the introduction earlier and for the invitation to speak here today. So hello to everybody. I'm a rheumatologist at Hospital for Special Surgery, and I'm excited to talk to you about an initiative at HSS to develop a registry to better understand the experience of our patients, you know, sort of being in the epicenter in the United States, at least in New York. When COVID sort of really struck here in mid-March, we felt that we should do something from a research perspective to try to better understand the implications of the pandemic on our patients. And so it was a large team effort to build a registry, but we really couldn't have done it without the many patients who contributed their own experience to this. So we really do appreciate all of those who joined in on this effort. Next slide, please. So we had two main goals when we set up this registry, two main sort of overarching goals. The first was to investigate the role of immunomodulatory medication use on sort of the risk of developing COVID and the severity of those who actually went ahead and got COVID. We also wanted to investigate the role of having a rheumatic disease on the risk of getting COVID and how severe COVID would be in those who actually did get it. You know, these are some of the questions that many people around the world are trying to investigate. Dr. Satoui touched on these as well. And, you know, we thought sort of being in the center of things, we could collect some interesting data on this. And some of the medications that I'm referring to, you've already heard a lot about in the previous talk, are listed here, but include, you know, our sort of classic medications like hydroxychloroquine, steroids, disease-modifying agents, biologics, et cetera. And then we also wanted to evaluate sort of the impact of the pandemic overall on our patients in terms of overall health and well-being, and to sort of see how it affects our patients who have systemic rheumatic diseases, some of which are listed here, and how it compares to other patients that we see who don't have systemic rheumatic diseases, but are also probably very impacted by the pandemic. Next slide, please. So what we did was we developed an online, secure, web-based survey, which was anonymous. We sent it to individuals, and it included at minimum approximately 50 questions. So again, thank you to those of you who really responded to all of them. We had 5 questionnaires in which we sort of divided up the topics that we were, you know, trying to assess. The first was we wanted to know all about sort of our patients' COVID exposures, whether they developed any COVID-like symptoms, taken any medications for prevention. And for those who did get COVID, we wanted to sort of figure out how many of our patients actually had suspected or confirmed COVID by testing, and who went on to get treated. Secondly, we wanted to evaluate patients by their rheumatic disease history. So we asked about that. We asked about whether patients had modified any of their medications, which we know, you know, anecdotally was happening. Patients were concerned, obviously physicians were concerned, medication doses might have been changed, medications might have been stopped. Thirdly, we wanted to evaluate, you know, the comorbidities that patients with rheumatic diseases might have, you know, diabetes, high blood pressure, high cholesterol, et cetera. We wanted to look at environmental exposures, smoking, vaping, pregnancy. Fourth, we also wanted to evaluate the impact of the pandemic in other ways related to health, you know, in terms of how, you know, in terms of access to care, in terms of access to food, employment changes, whether socioeconomic status, you know, really affected patients in terms of, you know, their experience during the pandemic, in terms of their access to care. And we know from looking at the general population and reading the news, you know, we know that this has been a major issue for our country overall. We wanted to see how it particularly affected rheumatic disease patients. And then lastly, we wanted to get an overall assessment of how the well-being and how patients are coping with the pandemic. And we asked a number of sort of patient-reported outcomes using a validated questionnaire to get at questions related to pain, sleep, fatigue, anxiety, depression. Next slide, please. So what we did was we went back and we identified patients who had been seen in the 2 years prior to, you know, sort of the pandemic at HSS. We excluded anyone who unfortunately had been deceased, or because we hadn't been able to quickly translate our survey yet into other languages, we excluded non-English speaking patients who we do hope to include in the future, and also pediatric patients, as this was an adult survey administered by adult rheumatologists. We then identified approximately 28,000 patients who would qualify for our registry, just who had been seen in the last 2 years and fit our criteria. Next slide, please. So we invited patients to participate by sending them this, you know, email that contained a link to the web-based survey. We collected our data for about a month between sort of the end of April to the end of May. We emailed, you know, approximately 26,000 patients, and we actually followed up with phone calls to a number of patients that we could who didn't have email addresses listed. Next slide, please. So we were happy to report that, you know, we had approximately over 8,000 patients who completed at least part of the survey, which was approximately 32% of those who we contacted. 7,000 completed that first questionnaire on COVID. So we were able to collect all of that data on a very large number of patients. And then we had over, you know, approximately 6,500 patients, which was about 25% of those who were contacted who completed the entire survey. So thank you again for those who did. Next slide. So, you know, this study was just recently closed. We are, you know, proceeding with our data analysis as efficiently and, you know, sort of appropriately as we can, but we don't have results yet. I did, however, want to mention, you know, some of the questions that I think you probably have and we have as your physicians in terms of how, you know, how to best sort of understand the impact of the pandemic on our patients. So the first questions I've listed here is, you know, what is the risk of developing COVID or having severe COVID in our patients who have rheumatic diseases? And some of our patients have long-standing rheumatic diseases. And some of the patients are, you know, have been on treatment for many, many years and have not had active disease. And, you know, some of our patients are taking immunomodulatory medications and some are not. Now, we don't have our data yet, but other studies have been looking at this. I've just highlighted a few here. Dr. Satui also mentioned some of this as well in the global registries work. But what I've listed here, the first one is a study that came out from Lombardy, Italy, which some of you may know was sort of the epicenter. Lombardy was the epicenter of the pandemic in Italy, where they actually administered a survey to approximately almost 1,000 patients who had been seen in 2 rheumatology referral centers there, and patients spanned a variety of different rheumatic diseases, and they had a very high response rate. And they actually found that the incidence, meaning the risk of developing COVID in their rheumatic disease population, was similar to the risk of developing COVID in the general population, which is important data and is useful to know. You know, now questions about how generalizable that data is to other populations, you know, need to be answered. But this was, you know, this is important data to sort of think about. The other studies that have come out, one recent one was published out of Boston from a large healthcare system, including Massachusetts General Hospital and the Brigham and Women's Hospital, where they looked at rheumatic disease patients who had COVID by testing positive for COVID. And they found that a similar proportion of rheumatic disease patients were hospitalized and had mortality compared to general population patients, so non-rheumatic disease patients, but actually had higher intensive care unit admission and mechanical ventilation. So meaning like intubation compared to the general population. They had a, it's important data because we need to understand this, but the sample size was, relatively smaller. So, it'll be interesting to see how this data plays out in other hospital settings in other cities. There was a Spanish study that very recently came out as a communication in the Annals of Rheumatic Disease, also showing that there was a similar risk of hospitalization and mortality in rheumatic disease patients who have COVID compared to the general population. And they had a similar sort of sample size of 41 patients. So, we're starting to get data on these very important questions. There have been other studies that I haven't mentioned here just in the interest of time, but I think this is evolving information and we should get more, information about these very important questions that are relevant to our patients soon, hopefully. Next slide, please. So other questions that we are, besides those questions that we're hoping to answer in whatever way we can with our registry, other important questions that, we've identified, and, we'd love to hear about some of your thoughts as well, are the following. So how, I mentioned that patients might have been modifying their medications. Were they reducing certain medications? Were they stopping and discontinuing medications? Were any medications increased? Who was making these changes? Understanding this is going to be really important for, I think understanding the role of, how often we need to modify medications in general, but also in case there is another resurgence of COVID later on, understanding, how to manage our medications in our patients is going to be really important. I also sort of mentioned this question of, disparities, which we're seeing throughout the country, which has been worsened by the COVID pandemic on certain minority groups, socioeconomic groups, et cetera. And, we're really interested in understanding this in our patient population as well. And there's a huge need for this. The question of pregnancy in rheumatic diseases is an important one as well. These, are pregnant patients at increased risk of COVID, of the complications of COVID, in general. And then what about those who have rheumatic diseases, and may or may not be on immunomodulatory medications as well. And, these questions also, need to be answered. And then lastly, and this is sort of, I think, a segue into Jillian Rose, who's the next speaker's talk, what is the psychosocial impact of COVID-19 on rheumatology patients? There's accumulating data in the general population. We're all affected by this pandemic. There have been, reports of increasing rates of anxiety, depression, and other factors. And so, we are interested in this topic as well. So, hopefully we'll have a future webinar where we can report the results of our efforts to you. But right now, I just wanted to outline, the work that is being done, to thank all of you who have been involved, and to tell you that, we are sort of trying to get to the bottom of these questions in whatever way we can at our institution. So thank you very much.
Thank you, Dr. Barbaya. Okay, and Dr. Rose, please take the stage.
Thank you, Dr. Barbaya and Dr. Satui, for your presentations. And as my colleagues mentioned, we know that COVID-19 disproportionately affects or people who are older adults or who are immunosuppressed or immunocompromised can be adversely affected by COVID-19, and that was echoed by both of my colleagues. We also know that we've been really staring at some of the health disparities that Dr. Barbaya started to mention and the challenges that those health disparities bring. Next slide, Margaret. So the Center for Disease Control reports that there's a disproportionate burden of illness and death due to COVID-19 among racial and ethnic minority groups. And the current data, which is really lacking at this time, and we're trying to do a better job as a healthcare system on that data, New York data shows that death rates among Black African Americans and Hispanic/Latinx individuals were substantially higher than those of whites or people who identified as Asians. These health disparities illness can be confounded further by socioeconomic situations, environmental factors, including living conditions, poverty, work circumstances, lower access to care, and underlying health conditions. So it's important for us to understand that as we design studies and as we research COVID-19 and its impact on people with rheumatic illness, there is no one size fit all. And it's important for us to include diverse populations in this conversation. Another conversation that we often miss and often lag behind that we do not intend to miss at our institution is a conversation about the impact of mental health on people with rheumatic illnesses. Rheumatic illness itself can have a profound impact on a person's psychosocial well-being. And we know that research shows that there's an increased association between rheumatic illnesses and the psychosocial conditions that a person can experience, including more prevalence of clinical depression and anxiety and depression really being doubled among people who are impacted by rheumatic illnesses. Depression and anxiety are also associated with poorer health outcomes and worse health-related quality of life and illness for people who may have RA or SLE. We know that social isolation and loneliness are also common among those with rheumatic illnesses, and research really highlights the importance of social and peer support, which can improve risk factors and disease outcomes. However, with COVID-19, being socially isolated or physically distanced can cause a lot of loneliness and isolation. Mental health concerns around the impact of COVID-19 are really looming in our population, and we have seen our patients come to us and be concerned about being physically distanced and following quarantine guidelines, but not being able to get the social support that they're accustomed to and used to that really helps to maintain their quality of life. We know that after disasters such as 9/11 and Hurricane Sandy here in New York, we saw a spike and we saw really higher rates in alcohol use, depression, generalized PTSD, and other psychosocial distress. So on the top of our minds is the mental health impact and the burden that our patients with rheumatic illnesses are carrying based on the psychosocial impact of COVID-19. I want to talk a little bit about the programs that we've been engaged in for the last 40 years or so at HSS and the Department of Social Work Programs. And the Department of Social Work Programs at Hospital for Special Surgery have the largest number of support and education programs for rheumatic patients and their loved ones in the country. Some of our programs are national, others of our programs are international, and we're really committed to providing the highest level of care to all our patients and their family members with a focus on serving diverse communities. You know, last year our programs provided psychosocial interventions, education, and support to over 22,000 patients, their loved one, and community members to really help them better manage and cope with rheumatic illnesses. We've also added to the evidence-based literature and have published several articles and abstracts on model disease-specific programs and interventions such as Lupus Line, Charla, Lantern, and the RA programs such as myositis and programs like myositis. Programs focus around myositis as well. Margaret, I'm sorry I didn't say next slide. If you can go to the next slide for us. We know that research shows that sound intervention really integrates the patient's voice. So we need you. We need your voice. We need to hear about your experiences, and we need to better understand not only how COVID-19 have impacted on you, your illness picture, but really your entire psychosocial health picture. And we really want to address those needs in peer-focused ways, in patient-centered ways, and include your voice in that research. Many of our patients have come to us and they're really focused on not on what medication do I take or do I decrease my medications. We're getting those questions as both of my colleagues mentioned. Margaret, next slide. However, a lot of the questions that we are getting are really focused on how do I manage the mental stressors of dealing with a pandemic and having a chronic illness and being overwhelmed because I'm immunocompromised. How do I integrate back into society? How do I go back to my doctor's appointment? How do I manage my telehealth appointments? And there's just a lot of increased anxiety that really causes disruption in a person's life and really impedes their ability to cope or even take care of themselves really well. So we want to really address those disruptions and really assess how those disruptions are impacting your life. So our study that we are launching next week is a needs assessment on the impact of COVID-19 on people with rheumatic illness, with a specific focus on using standardized tools to understand the impact of depression, anxiety, loneliness, the lack of access to care. We want to know about your self-reported physical health, your self-reported mental health, your access to care, not only physical and medical care, but also vital social services that people need at this time. Also your support and education needs. The information that we gain from this study will be a national study and you can take it online. The information gained will help us to look at medical care, help us to look at mental health care that we provide, as we are a lupus center that is very focused holistically on the patient. So we want to understand what better support and education programs we can plan for our patient population and how we can inform future programs, understanding the diverse perspective of our patient audience and not neglecting that piece, because we know that COVID-19 is disproportionately affecting different people from different populations, people from communities of color. And so we want to ensure that we include those voices as we prepare to intervene and to support our patient population.
Give your contact information is right here in case anybody has any questions or for more information about that study. Right? Very good. Okay. All right, thank you, Dr. Rose. Thank you to our three panelists. We're going to stop our formal portion now. We've got a lot of questions I see here. So I would like to start off our question period. We might, if people are willing, go a little smidge over. First of all, we got some questions from our audience members prior to the program, and if our panelists will unmute themselves, then they'll be able to answer our questions. So Dr. Satui and Dr. Barbaya, please unmute. Okay, so one of our questions here, Dr. Satui, are there some therapies for COVID-19 that are currently being studied that lupus patients would not be advised to take?
So the answer, so multiple medications, like I said, rheumatic medications are being studied right now. Specifically, like the ones I mentioned, which are tocilizumab and anakinra, are medications that are not commonly used in patients with lupus. There are some other medications as well, like TNF inhibitors that are being studied, not currently in the US, but in some other countries, I believe, for treatment of COVID complications, that again are also not commonly or routinely used in patients with lupus. So that being said, I think there is not a specific, neither of them are specifically like contraindicated, but they're all under investigation. So I think conversations regarding the use of these medications in patients with lupus need to be addressed, and the history of lupus needs to, of course, be part of that discussion as well, including the fact that what we know is that we, in rheumatology, we usually try not to kind of couple those two biologic agents. So meaning we don't use two of them at the same time. But again, this is kind of unprecedented territory, and some of these decisions could potentially kind of be life determinant. So this needs to be kind of discussed between the patient, family, and the physician in case it would have to be needed.
Okay, thank you. We had a question about the new vaccine. So will SLE patients be recruited to trial, say, the Moderna vaccine or any of the other vaccines that would be out there?
I can try to answer that question. I'm not involved in vaccine development, so I'll just mention that from what I've read and what I understand, the current exclusion criteria for for example, for the Moderna trial, does exclude patients who have immune-mediated diseases or who've been taking immunomodulatory or immunosuppressive medications prior to enrollment. So I think currently, at least in what is currently published and available to the rest of us to learn about, it doesn't seem that way, but I can't predict in terms of future trial enrollment what would happen. But so far, not at this time.
Okay, so as a follow-on to that, so if once a vaccine is approved, can people with lupus or with a low immune system because they're taking immunosuppressive drugs, would they be able to safely take a vaccine?
Yeah, that's a great question. It's something that we would have to sort of figure out at the time in terms of, it will depend on the vaccine trial, what the inclusion-exclusion criteria was, what the results were. There's a lot of other studies that would probably be done on these vaccines to better understand the implication in patients with, immunodeficiencies or on certain other medications. And, it very much will be sort of a case-by-case basis, trying to figure all of this out at that time. But I do hope that our patients will be eligible to receive these vaccines. And at this point, I don't necessarily anticipate that there would be a reason not to.
Great, thank you. So we have a question here. How well controlled are these studies in terms of accounting for comorbidities? And so is the lupus itself responsible for more hospitalizations versus other conditions? Or is that, the many comorbidities, are those responsible for the severity of the disease and the hospitalization? Dr. Satori, do you want to field that to begin with?
So the thing is, when you're trying to talk about controlling for other, what we call confounders or comorbidities, that depends a lot. And this is kind of one of the reasons why kind of there's I guess power in unity and collaborations worldwide, is how much other things you can control for in a study depend on the numbers that you have at baseline. So if you're talking about the smaller studies or the smaller experiences, for example, like the Italian one, or even like I don't remember the numbers for the Spanish one, but all these small kind of letters and publications from different groups in Europe, the numbers are so small that it's certainly difficult to actually control for all this. So what in the paper from the GRA that included 600 patients, comorbidities were included. Again, why? Because you had 600 patients, and that allows you room in order to put other factors that you can control for. So yes, in those cases, yes. But I think, again, more and more things are going to be coming out. But the question goes straight to the point that it's important to actually control for this, because what we know is that independent of having a rheumatic disease, all these other conditions actually put you at a higher risk. So that is what we need to be looking for right now. But I think it's hopefully with time, bigger studies will be available in order to control that.
Great, thank you. Okay, so here's a participant asked, so I'm wondering about the makeup of the population of the study. So were most of the individuals who were included, were they European and therefore white? And so since lupus affects Black and Hispanic people disproportionately for those populations, is there a study that's including these groups? And were most of the people women, or were they men and women?
Well, I guess I can start, and then Dr. Barbaya can continue. But that is also part of the interest of having data from different places, because it's like, as mentioned in the question, yes, like the population, the diversity of populations is going to be completely different when we're talking about the US and then when we're talking about Europe. So that's why I really don't remember exactly the kind of the numbers for the 600 patients included in that analysis. But like I said, from the 3,000 patients that have been included in the registry so far, a third of them at least, or a little bit more, are from the US. And there you're certainly to some degree, because of the diverse population, they are going to be part represented. How much? It depends a lot. This implies for people to actually have to go in and actually put the data in, log the data in. So that's why it's important as well for patients to be part of this and to actually report the data, for physicians to be involved, and that data collection is key. If people don't go into any of this kind of registries or surveys and so on, and answer them, then we're going to be limited in how much we can present. But yes, at least from the all of this is being taken into account, and certainly I think population-wise, the U.S. will provide a lot of this, specifically from the diversity standpoint.
Dr. Rose, do you want to comment about the importance of people participating?
Yeah, I think what Dr. Satui shared is important. I think also taking responsibility as clinical researchers that we need to advertise our study and share our study and the importance of our study and engage our patients who are diverse in participating in those studies. As I cited before, oftentimes patients who come from diverse backgrounds are on the front lines working, they're on the front lines being the person who's driving the bus or being the person who is in the emergency room as your nurse or as your PA. And so it's important for us to think about creative ways of how we engage those voices. And those ways are not our traditional ways of just putting them up. So engaging with communities, engaging with community partners might be good ways, and engaging with patient advocates might be also good ways of using their platforms to share our studies and share our work.
Great, thank you. We have a question about people who have both lupus and APS, or the lupus anticoagulant. So they're concerned about the frequency of clotting in people with COVID, which has been seen now. So what do we know about clotting rates in people who have APS or who have the lupus anticoagulant, and when they contract COVID-19?
I can try to answer that. Sure. There are, yes, it's a great question. There have been a number of reports showing that, patients in general with COVID have had, increased risk of blood clotting. And a whole slew of, probably in the last month and a half, of reports have come out suggesting a potential increased risk of antiphospholipid antibodies, such as the lupus anticoagulant, being positive in some of these patients. Not all, but I think we really don't understand the underlying mechanism of blood clotting in COVID right now. Sometimes antiphospholipid antibodies can be seen just to become transiently positive in very sick individuals who don't have rheumatic diseases, don't have lupus, don't have antiphospholipid syndrome. We sometimes see it, just even before COVID, we've known that sometimes antiphospholipid antibodies can become positive in patients who are very sick. So it's really hard to tease this out. There have been a number of studies that are trying to better understand the association between antiphospholipid antibodies and the development of blood clots in COVID. And I think the data is still out there right now. We're still trying to understand this better. The studies need to be designed a little bit better. There's a lot of effort, I think, worldwide, including at our institution, to try to better understand this association. But for now, I think it's an interesting question. It's an important question. But for our patients who have these antibodies, and for now, they're patients who already have antiphospholipid antibodies, we don't have any clear indication that there is an increased risk of blood clots. If you were to go on to get COVID, we just don't know that information yet. Hopefully we will in the future.
Okay, and sort of related in a sense, because we're talking blood. So is there a known link between blood type and COVID severity? Either Dr. Satui or Dr. Barbaya? If you're A positive, there have been some reports of that.
There are some reports.
Is there any?
There are some reports. I think, again, this is all very preliminary. It's certainly something to keep in mind, but at the same time, I think being to a point that I'm A positive, and therefore I need to get medications earlier to avoid my COVID from getting worse. I think we're not, I'm no way anywhere close to that. So I think, again, this is just preliminary. We're still trying to understand this as the APS antibodies and so many other things. So kind of, hopefully at some point we'll have better information.
Okay, thank you. We do have still people have concerns about managing life under the less strict guidelines for sheltering in place. So questions about traveling by airplane, by returning to work, teaching in a classroom, renting a private office, air circulation in an apartment building. Dr. Rose, would you like to talk about, how people, guidelines for people managing their lives as we reopen more.
Yeah, thank you, Margaret. I'll talk a little bit about thinking about, you know, confronting your current reality. I don't quite like the term returning to new normal, because none of it is really normal. So really confronting your own reality is going to take some planning. And in instances, we've talked with patients, if you are taking the train to work, or if you're taking a bus to work and you haven't gone back yet, take some time to show up to that bus station, assess how many people are getting on the bus. In New York, we have the rear entry now, so that's different than before. See how you're feeling with that. I've walked with patients in terms of them going on the train for 2 stops, and we know that they have to go 10 stops to get to work. We've been advising our patients related to coming back to healthcare and coming into their in-person appointment. And some of the things that we've been sharing with them is, please call ahead. Call ahead to better understand, what are your care facilities doing to keep you safe, and what are the new guidelines. I know at our facility, we are doing temperature checks, we have your mask for you, and we really have a good process about that. We also have socially distanced space in the waiting room. We've taken out some chairs. In your doctor office, the waiting room might look a little different. How many people can accompany you might be different for some facilities. So taking some time to find out what your facilities are doing to keep you safe, and really planning ahead will be important for you.
Great, thank you. We've gone over time, and everybody who's still with us, thank you so much. Thank you to our speakers. I will wrap up with one final question and then conclude. Given that it's theorized that the development of lupus can be spurred by a viral infection that your body never stops fighting, do researchers anticipate an increase in lupus and other autoimmune conditions post-COVID-19?
I can try to answer that. I mean, that's a great question. It's a question that's been long-standing in the rheumatology world in terms of understanding the underlying role of environmental factors in the development of disease in our diseases. There's been concern for many years about whether viruses may play a role in the development of rheumatic diseases. And it's a difficult question to study. It had been previously. Now in the setting of COVID, sort of the silver lining may be that this might sort of afford an opportunity to identify this question and try to study this moving forward in patients who have recovered from COVID, to better understand the role of viruses in potentially causing rheumatic diseases or other, immune-mediated diseases. We don't know that yet. I know there's a lot of interest, myself included, to try to better get at this question. It will require time to follow patients who have recovered from COVID forward to see, and a lot of organization and a lot of, follow-up. But hopefully, we'll have some of this data moving forward. So it's a great thought, and hopefully answers will come in the future.
Great, thank you. So I want to thank our panelists for being with us today. More importantly, I want to thank the audience who did take their time today to join us and to get this information and pose your questions. So as I said, the program will be recorded, and it should be on our website in approximately 2 weeks. In the meantime, there's a lot of great information on the website, a lot of resources for patients. So you can visit us at hss.edu/lupus center, and you can play around with all the different resources that are there. Also, we love to hear from you. So if you would like to get in touch with us, you can email me at lupusapscenter@hss.edu. Now remember that a browser is going to open up after we close here, and it will present the survey for you. We really appreciate if you do fill out that survey. It will help us serve you better. So we hope you will join us again for another program in the future. And in the meantime, we wish you safety and health to you and your loved ones. Bye-bye.